Election, you'll never get it. All these are the ones. Now here you see, this is a peculiar type of a lower one third now, the lower subclass. I suggest primary augmentation with side primary augmentation with the side plate in such unstable comminuted subclass. Nailing alone is not good enough here, even though it is a lower one third, but there is a combination there. This is not going to heal up so easily. This is a transverse fracture, combination fracture. The nail is not stable in this area. So this is the one which will go into non-union. You can see the lateral view. So this is after 4.5 months stabilization plate, and the whole thing heals up perfectly well. This I propose on day one to an augmentation plate. Don't hesitate. Overkill is not a sin. If there is a security of a prime minister, is always an overkill. Treating a human being on day one, overkill is not a sin. This is the one I treated it. Badly comminuted, subpropentric, lower one third, though still put it with the hair. On a day one, patient walking about with the support, and the things start healing. This is again the second one, comminuted, osteoporotic, segmental side, or osteoporotic augmentation, patient starts walking about. These are the ones where if you don't do it, they just break down. I'll augment this, as I say, on day one. Now, here was the fracture. Surgeon treated this with a nail which broke down. He treated with this fibula from here, put in augmentation plate here, a thin little, piddly little plate. This video is not working, it is moving rapidly. This is the stage I came because of this patient had a foot drop. And then 5.5 years, she went on with her treatment in order to walk first time, better that also with a foot drop. This is the one augmentation was done, and slowly all this filled up in 26 months' time. This is the day one, such comminuted subprop, day one, augment with a plate and a graft. I feel this is the treatment, this is the plate which you put it on this. Again, this fracture. Comminuted, nailing, failed, plating, failed. Second stage, nail and a graft and a augmentation plate. On day one, such a comminuted piece, I would have repositioned circlage wire, augmentation plate, and this is the way I would treat it with the nail. Actually, I have not drawn the nail, and I would have put the graft. Nail is a must here. Only plate is not enough. This is the fracture as I showed you. We went through the cycle. All you can see, bad reduction. Again, this MIPO. I think MIPO to me has done more harm than good. MIPO is good in situations where you can execute a good MIPO. But the reduction compromise is not the treatment, the MIPO. Again, you can see the CT scan. Some second surgeon did this. Again, very competent surgeons in Bombay. Not necessarily they were incompetent surgeons. If I give you the name, you'll be surprised. These are all competent surgeons. Basically, subproc phobia, nailing is the treatment. This is what it happened, and then it came and it had to be augmented again. And then nail, there was good PFN because everything was shattered. So I put in the enders, people plate, massive bone graft, and this is the BMP protein, which is put in. The BMP is 2.5 lakhs per in situations. I feel that BMP in such situations is going to be very useful. Again, all these factors, point of entry. You put a point of entry into the trochanter, it will hit here, it will break, like this what happened. Fortunately, it held up, but the point of entry has to be in the piriformis. Piriformis point of entry, the nail has to go parallel to the left border of the. If it doesn't go, you are going to have a problem. Again, the second case. Again, all of this has been done by very competent surgeons. Again, a second case. The same point of entry. It should have been piriformis, parallel here. If you needed a bolus screw, then only it would have been all right. Again, a point of entry issue. Point of entry, you can see, has shattered the whole trochanter. So, point of entry in subtrochanteric fractures, upper and lower, is always a piriformis, in piriformis only, and not in the tip of the GT. Point of entry in subproc, this is the one which you go out to the tip, not on the tip, go on the inner side, then it is in the axis of the femur, and you will be able to get the whole point of entry back into that situation. Point of entry. Rotation correction, lesser trochanter, patella, ankle. And if the lesser trochanter is seen prominent in a AP view, then externally rotated is the fragment. Adduction judged by AP view and leg shaft angle. And flexion is obviously visually. All this you can see problems of a upper subproc. You will not be able to solve this just by any other hardware except a nail and a plate. Now this you can see, this is an orthopedic surgeon's wife from one of the city, which you can imagine the senior most surgeon and the most known surgeon must have operated. Again, this subproc, nailing, same thing which I described happened. This piece went out, this piece became loose. Point of entry should have been here. So he came to me at this stage. This piece was separate, this piece was separate, this has gone away, nail broken here. I went in, corrected, put in the nail, put in the plate, in the graft, and we start walks about. Such a subproc, if you cannot put in a traction, obese patient, put it in a lateral position. Put in a lateral position, put in a nail, put in circular wire here. Now I would have put in probably a small plate today. All this medial gap is unstable. If the medial gap is unstable, this will break down. So the medial is the most important here. in a plate. This is the gap here. So it was filled up with bone and then it heals up. So even when you do a plate, medial gap has to be seen and it has to have a good amount of bone graft. At that level, metaphysical level, you may not need an autograft. You can put an allograft or even a hydroxyapatite, still it will work. The medial gap, again here you can see. Good hydroxyapatite being held up. Again, the medially is good, so everything goes fine. Now here, execution of nailing and high subprop, you can see this is the normal thing. The nail neck has to be appearing like this. This is always it appears the way the upper fragment is externally rotated when you're trying to do the nail. So you will have that small deformity, patient can still carry on, but is not normal. If you're treating a high profile patient, then you will have a problem. I described one of the Gujarat, which all of us have heard it came in newspaper. Gujarat police inspector, IT fracture treated in Ahmedabad, got a collapse a little, got an adductor lurch, filed a suit against the surgeon. It went on like that, and the surgeon was charged with 2 crores of rupees for compensation for that. So high-profile patient, abduction lurch is a big issue. And he was right. I had seen the patient professionally. He was right. He said, how can I work as a police inspector? So we take it for granted. We show the X-ray that the fracture is held up. That's not the issue. Function, how good it is. If there is an abductor lurch and he cannot walk more than 100 feet, he gets exhausted, he gets tired. This is what is abductor. This is external rotation which occurs. Fortunately, the patient may not have a major problem. So in conclusion, subprop better with plate. All subprops with communicated nail and a plate better. Plate medial gap needs grafting primarily. Overkill is not a shame. I would still do an overkill today without any hesitation. Thank you very much.
Thank you, sir. Thank you.
Any questions? All right. Sorry. I can't hear.
What was the cause of abduction lurch in that patient, which you told that
Virus.
abduction lurch? Yeah.
Virus. He had a 3/4 of an shortening and a virus. Once there is a virus, abductors are compromised. And I know that patient, I was a part of the thing that he was ultimately had an abduction osteotomy. And that shortening was corrected and abductor lurch was corrected to a fairly good extent. Yes, Amit?
There are certain cases wherein those medial gaps in subtrochanteric fractures do not need to just cancellous bone graft. A strut graft needs to be put over there.
It's fine, it will give you a better stability. I have no issue.
And
but that will be when you're putting a plate, which is a strong plate,
yeah.
Then you can put in a cancellous graft or hydroxyapatite. But if you're putting a nail, then it needs the stability. Then probably what you say strut graft will be a better option.
So if it is a nail, it should be along with a blade plate or a small plate also is okay.
You need a plate like normal things. I put in a long plate.
The GTR plate.
Yeah. And I am fond of a hook plate rather than the other plates. Because I feel the hook plate goes well into the trochanter. Yeah. It bites it there and once through there it gives you the stability.
One of the cases showed that there was a
Hey.
but that plate broke.
That was a plate which was a piddly little 2.5 plate. And short plate as you could see. You need a longer plate for stability and 2.5 will not give you stability. That's the reason all these plates are 4.5. The hook plates all I have done, they are all 4.5. Yes, Amit? Mine.
All cases you showed, you had a lateral plate along with the augmentation plate. But what my observation is that most of these fractures would ultimately fail with an apex anterior deformity. So wouldn't it be better if we place the plate?
Good question. Good question. If you have a nail which is correcting that deformity, I observed initially I tried to put it more anteriorly because they are going to bend it there. But you put in a lateral plate which is a strong 4.5 hook plate like this, that anterior part is automatically corrected and it doesn't make a difference. It is initially I did an anterior plate, but then anterior plate is the hook will not come in there and it will not really.
Just a regular blade, sir, not a hook.
A normal plate.
A normal blade.
I have given it up. I had tried it earlier, but I have given it up.
Okay, because
Right or wrong, I don't know. This is what is my.
because I have done about 4 or 5 cases with
It will work.
a sort of non-union with blade plate and an anterior plate.
I entirely agree. I mean, it will definitely work. Once the double implant, it will definitely work. As you said, plate and a plate, nail and a plate. Plate, you put it on side or you put it on anteriorly, it has to work.
In most of your cases, have you given attention to the beak going outside, that the positive variance in a subgroup with IP?
Again, in an intertrochanteric fracture, it is very, very important that it has to have a positive reduction. In a subproc fracture, when doing a plate, that's not important.
So,
That you need the anatomical reduction. That's the one which gives you stability. If you are doing a nailing and plating, again, I feel it's not significant. But if you are doing a PFN in an IT fracture, the positive reduction is a must.
generally, it is said that if it's a positive variance, you get a valgus at the head.
Perfect. Because if you put a point of entry from piriformis, you're bound to get their valgus. And because if you go to the GT, even if you do positive reduction, that valgus doesn't come. If you try to push it, it automatically goes back, as you have already talked about it so well.
Thank you, sir. Thank you. Now I would like to invite Dr. Amit Mishra to give his deliberation. Dr. Amit Mishra, please.
Good morning to all. Thank you, sir. Thank you, POA, for inviting me for this session. I am presenting here a case on tibia fracture, proximal tibia fracture.
सीधा करो बीच में.
In the meantime, I will request Dr. Kapil Kulsher to honor our past UPO president, Dr. Amit Rastogi, with a stroke.
Thank you, sir. So I'm presenting. This is a 45-year-old male. Sustained a high velocity migraine injury, presented to us with a severe pain, swelling, and something like implanting compartment syndrome. This is the X-ray. How to proceed for this fracture? The concept is to first to span, then scan, and then go for the definite fixation. But sometimes we don't follow the exact rule. We get this calcaneal pin traction, and waited for around 7 days for the subsidence of the swelling and appearance of the wrinkle sign. After that, we plan for. This is the CT. The pictures are not very good, but the CT is showing the fracture. All the 3 columns are fractured. The posterior, medial, and the lateral column. Then, how to approach this patient? What is the position of fixation, the reduction tools, and the implants? Usually, the posterior column. This is the column concept. The 3 column fractures defined as at least one independent articular fragment in each of column. Most of the time, this is a bicondylar fracture with a separate posterior lateral fragment. Saturated type 5 and type 6 are considered as 3 column fractures. This is the X-ray again. So we plan it to fix all the 3 columns with the 3 plates. This is the initial X-ray where we initially fix the in a posterior column first, then the lateral and the medial. The position taken was a supine position with figure of 4 for the posterior column. This is the X-ray around 2 or 3 months after the procedure. The fracture is healed well, and this is the functional result of the patient. I would like to present one more case, similar case. This is a patient which is 46-year-old police personnel presented to the emergency department after a bike hit, presented with cross swelling. Again, the patient was put on the traction, and we had waited for 5 to 7 days for the swelling to subside. And this is the CT scan we get. In this fracture also all the 3 columns are fractured. There is a major posterior fragment, and in this patient we had initially fixed the posterior column in a prone position, opened it posteriorly and fixed with this posterior plate. So to conclude, the CT scan is mandatory for planning how to get a good reduction. Stability is the goal. Don't hesitate to use more than 2 plates. Address every column individually, and the goal is early mobilization of the patient. Thank you.
Thank you. Now I invite Dr. Ram Prabhu for his deliberation. Good morning, Chairman, Co-Chairman, my senior colleagues and my friends. Again, it gives me a great pleasure to be here at this great call, to be amongst you, talking about a couple of topics of trauma, which are quite dear to me and for all of you too. So today I'm going to talk about the tips and tricks, especially in the lower end of trauma. And I must thank my colleagues who have helped me with this presentation. First of all, we have plenty of implants. We have plenty of plates, anatomical plates, contour plates. We also have nails, but we must remember that no implant is idiot-proof. Because the surgeon is the most important part of the surgery. And whatever best implant that you use, they have to be used properly and in the proper principles. Because as you see, I'm talking about the plates only today, not the nails and the externals, etc. This has been the best, one of the best plates that has been used for the lower end femur fracture. But the way it has been fixed, you can make out that this was a disaster on the first day itself. So we call it a day one failure. And this is not going to give you adequate and good reasonable results at the end. So the plates need to be used properly with proper principles, the proper surgical technique. And this is how the plates can be sometimes disastrous even if it is good. So no implant is idiot proof. So patient has submitted to you and you have to be responsible for his treatment. The second is know the patient and the fracture welfare. It is extremely important that the patient whole is important whenever there is a fracture because that fracture could be in a different types, different classification, and we have to know the pathoanatomy of that fracture. For example, all the distal end of femoral fractures are not the same. If you see these badly comminuted fracture, sometimes it's segmental, intra-articular, etc. And to add to the insult of this injury, we can have an open fracture or sometimes bone loss. So all these fractures have to be treated with its own merits and they have to be treated properly. So these fractures could be the same lower end femur fracture, but with much worse complications which can occur. Again, in the lower end of the femur fractures, we must remember that there is HOFA fracture and it constitutes almost 40% of the distal end of the femur fracture. And that's the reason why we have to take a CT scan in the lower end of femur fracture. So all those fractures who you suspect or even if you don't suspect, all of us know that, and that further away. So it is further inferior. And when we are reconstructing this femur end, we have to remember this pathological or the physiological aspects of the femur. Again, when we see the lower end of the femur, the cross section shows a trapezoidal shape. This is what is important. The trapezoid, this needs to be reconstructed. We should know that on the medial side, it is inclined about 25 degrees, and on the lateral surface, it is internally rotated by 10 degrees. And these small points are important when we, especially these comminuted fractures, and we have to get the jigsaw puzzles into place. So fortunately, most of the implants have this inbuilt, this inclination, etc. is inbuilt. Anteriorly, we must remember that there is a slight angle of 10 degrees. So medial and the lateral condyles coalesce, and this is for the patellar tracking, which also needs to be properly reconstructed. Again, anteriorly, the trochlear arch is well seen in the lateral view. You can see this. We can see the Blumenfeld line. And this is what is again important in the X-ray when we are putting it. Because in the lateral view, this Blumenfeld line represents anterior and the posterior limits of the intercondylar fossa. And this is very important to know because when we are going to pass the screws, they have to be in the upper part of these Blumenfeld lines. Because this, if you put it, it will go into the intercondylar fossa. It will also damage the cruciate ligament. See that the screws have to be about this. Again, we must know all the implants that you are going to use. All those implants have some variable degree of modification because because all the companies have a little different modification and they say that this is a very good and the best implant. But that is not so, because we must know how this implant needs to be properly put. Understand the biomechanics of every implant. Because some plates have a larger this, and that has a specific reason for which it has been made. Again, when it is a comminuted fracture like this, we must know the plate length, which is 3x comminuted length, and the whole screw ratio also has to be remembered. In the diaphysis, it is about 50% of the holes which need to be screwed. That means if there are 8 holes, you have to at least put 4 screws in the diaphysis. In the comminuted fracture area, we don't put any, and in the metaphyseal diaphyseal region, about 75%. That means if there are 8 holes, at least 6 holes have to be screwed. So we must remember, the surgeon, that not every hole needs to be screwed. This is a bottom line, that the surgeon should not go after every hole and screw it. And then there comes the position of the patient and the good X-ray on the table. So this is what is important. If most of these fragments are flexed, the distal fragment, because the gastrosolius is full, and this is simply by putting a bolster behind, a round bolster, we can get that gastrosolius relaxed and we can get a good position. So this is very important. A simple position will help you to get that alignment. Again, when we take a CR view on the table, we must have the AP, we must have the lateral, tabletop lateral, we must have notch view and 25 degrees internal rotation. Now I'll tell you the importance of each CR view that has to be taken. The notch view is important, and it is taken by cephalic field of CR by about 20 degrees, 25 degrees, and that will show us if the screws are going into intercondylar notch. Because if that is going, of course, that is going to be detrimental to the ligaments. So we have to be careful. By taking a notch view, we'll be able to find out the intercondylar fossa. If that notch view comes in the AP, suppose you take an AP X-ray and you see that the similar notch view you see, then you realize that the disc is reduced in extension. This is what happens. In the AP X-ray also you have seen the notch view. It's like a cephalic tube, and that shows that this is hyperextended display. Then internal oblique view is very important to find out the screw length, because the screw length appears short in the AP X-ray. If you take an internal oblique view, we'll realize that this screw length is inadequate in many of the cases, because the screw length is actually less than what it appears. Again, the crux of the matter is have good images during the review. That is very, very important, because many times you get this surprises post-op when we actually take the X-ray, because in CR we cannot find out whether the screws are more or less in length. Have full images at the end. So we must have full images of the whole femur, even if you have used only the distal part, and interpret these X-rays very well. And act on the information. So CR has a limited vision. Many of us have 9-inch CR, but even that is not adequate in most of the cases. Again, 6 point is the most important. You cannot get away with inadequate anatomical reduction. So reduction is the key of all these fractures, just like any other fracture that we manage, even subtraumatic that Sir Tanna showed us. So accurate or articular reduction is the key for getting success of this surgery. And convert the C-type fracture into A-type by getting proper alignment with the jigsaw fracture. And this is, if necessary, you may have to do an arthrotomy. So don't go in for MIPO if you think that the reduction is not going to be adequate. So please open the fracture, just like Sir said, MIPO can be disastrous many times, because it cannot give you an accurate articular alignment. It's challenging to achieve a reduction when there is a bone loss. If there is a bone loss like this, and many times this is open fracture, it is very difficult to get that aligned. So in those cases, if necessary, we have to do an indirect reduction. We can use a distractor, we can use external fixator, or various different types of plates that are come, or sometimes even nails. So, it's important to have an axial alignment, it's important to have an anatomical alignment, but it's difficult in many cases. And if implant position has to be spot on, and that is again very important. It has to be controlled to the bone, and we have fortunately this implant nowadays. The first wire or a drill that we put from the lateral aspect should be parallel to the joint line. This is again important to have a proper placement of the plate. Aim slightly posterior and inferior in the lateral X-ray so that we get this screws in a proper axial way. The plate position, you will see this, that if you don't put a plate properly in a, okay, so if it goes little distally, it immediately causes the golf club deformity, and which is not desired. So we have to have those plates properly placed in the proper distance from the articular area. Anteriorly rotated plate will lead to screws in the intercordial fossa. So this plate has been rotated anteriorly, as you can see. It is much anterior than what it should be, and then those screws go to the dangerous area where the popliteal vessels are there. So we have to prevent these disasters, and we have to see that these plates are properly placed. Again, plate too proximal like this. About the anterior part, proximal screw also can have problems. They can go into intercordial area, and it can be disastrous. Again, lateral view to be checked for sagittal alignment of the plate. Try and match the posterior cortex. This is the posterior cortex, and the lateral view, you must see that the plate is almost parallel to that posterior aspect. Again, as I told you, plate position needs to be absolutely perfect, and we have to have anteriorly 1 centimeter from the vermilion. This is called vermilion. Anteriorly, that is the border of the femoral condyle. This is what has to be taken properly. This distance. Okay, otherwise it will have a helicopter effect, and that is going to be disastrous. So plate should be applied with the flare, and this is X-ray. Because in this case, this plate has gone like a helicopter, that is what we call it, helicopter effect. And if you see in the cross section, this has gone crooked. And that is not desired, because one of the patients that we did, we operated, we kept the plate, and the resident had running. And that plate just came off when the patient was being shifted on the trolley, it just broke. So that is a weak point of a stress riser, which has to be avoided at all times. So we meticulously get that alignment well, and the plate has to be absolutely put well. In very unstable situation, we have seen plenty of cases where there is a medial loss, and in those cases, don't hesitate to do a bilateral plating. As said, now overkill is not a shame. So if you think that this is not going to work well, on the table, go ahead and do a medial plating. If necessary, some of us have done tubular strut graft, or our in Bombay, somebody uses cage with the bone graft, and that cage could be used to augment on the medial aspect. Eighth is MIPO is not only a small incision, because MIPO has been misunderstood. People think that it's a minimal invasive, all the fractures can heal because we keep the physiology well, but that is not the case, because alignment is extremely important. In this case, especially, people have done MIPO, and you have seen that this is aligned absolutely well, and this is going to have problems, not only in union, but later on also in the motion. And this can happen in lower end of femur very often if you don't do it. So in MIPO, there are proper steps that we have to take. We have to do the find out whether this fracture is good enough to do MIPO. We have to plan it very well, because MIPO needs much more planning than the open reduction. Open reduction, many times we take some opinions, or we do it on the table after the fracture is open. the approach has to be thought about how the plate is going to be minimally sent inside. Reduction, direct or indirect, needs to be done. Stepwise increases stability by temporary fixation by KORs, and we have to see the axis and the rotation that has to be checked, and finally we have to fix the NIPO. And all these steps are extremely important if you are going to undergo NIPO technique in femoral lower end. Nails useful, but in some unanswered questions. We can also use nails in the lower end of the femur, but since it is Plateseon, I'm not going to dwell upon it. There are proper indications for doing nail. It is a faster procedure as compared to plating, bilateral femur, multiple extremity fracture, if there is a floating knee, etc. Then the nail is useful in those cases. Sometimes if there is a vascular injury, again, nail can stabilize this fracture with the management of the artery. So this is how different way, but it is important that we must not have varus or valgus in this. So we have to again align those fractures with the nail too. There are unanswered questions in nail, like the lower rates of union, long-term effects of articular function if it is past the retrograde nail, long-term effects of cruciate ligaments are really not answered. And finally, if you have to undertake lower emphysema fractures, something one must read. We have to be extremely well prepared with a proper some series of how this should be done, etc. This is an excellent paper from 2011. Locking plates for the distal train femur fractures. Is there a problem with fracture healing? And this that you must read, all of you. Then pitfalls in the application of distal femoral plates in fracture, a must before doing any distal femoral fracture. So friends, there are these 10 commandments for lower end of femur fractures which we have to do. And in conclusion, results vary widely on all these cases because there are different types classification of this fracture. In many series, implant failure was because poor surgical technique. An improperly used implant can definitely not give you reasonably good and adequate results. So you must remember that we must know the implant and how it is going to be used in this fracture. Thank you very much.
Thank you, sir. Is there any question for Dr. Ram Prabhu and Dr. Channa, sir?
Again, it depends on what kind of, is it a comminuted fracture, transverse fracture, oblique fracture, but it has to be as close to the fracture if it's a single fracture or a transverse fracture. Okay, again, it depends on whether it's going upwards or there is a diaphyseal involvement going upwards. So there is no fixed answer to your question that it has, how much distance. It varies. It should not go in the fracture. Okay, thank you very much.
I will request to please get forward. I will request our chairperson to please take, just wish to felicitate them. Now for the next session, I am inviting Dr. D.K. Srivastava, Dr. Piyush Mishra, Dr. Manish Shukla, and Dr. Akshay Chandra to chair the session. I will request Dr. Amit Rastogi sir to kindly chair the session. And Dr. Tribhuvan Singh sir. Now I'm requesting our chief guest and star of the day, Dr. Ram Chitta sir, to kindly give his deliberation.
Respected Chairperson, sir, and my dear colleagues. My brief today is communication skills and teamwork, a must-know today. Success in orthopedics, as we look at it, is a combination of effective communication and teamwork. A team is an acronym where together everyone achieves more. What is success? Each one of us has a different interpretation of success. But literally, success is when reality resembles our imagination. जो हमने सोचा वो हमें दिखा और हमने एहसास किया तो सक्सेस माना जाता है. Effective communication is when a person wants a desired outcome by sharing key information or news. News is something that comes from north, east, west, and south. Teamwork is not a group of people who work together, but a group of people who trust each other. I've spoken on trust beyond what I could last evening. Finally, success is effective communication and teamwork to achieve that purpose, that passion that you wish to actually deliver and make a dent in the universe. Unfortunately, the dent we make or wish to make hits us so very often. We doctors are assaulted. I come from Mumbai, Maharashtra, Sion Hospital, and I share with you 5 instances where more than one attack was made on our brethren in the past few years. How do you handle a situation like this? And it happens very common with spine surgeons, orthopedic spine surgeons, and I'm sure with trauma surgeons. Unhappy relative of a patient who has a post-operative adverse event barges into your packed clinic and insists on seeing you immediately when you are in consult with another patient. This is what the relative looks like. Very, very difficult and overwhelming situation. Do you stop your present consult and see him right there? Do you finish your present consult and see him later right there? Do you politely have him seated in another room and see him after the present consult in the other room? Or do you have the guts to, and believe me, someone said he did, admonish him and get your support staff to make him wait outside? Well, I am not as courageous as a friend of mine who opted for option D. I would choose to politely have him seated in another room and see him after the present consult. Ladies and gentlemen, when we have situations like this, our patient is out of focus. It is the caregiver, the attender, who has those peering, deep-set eyes, which actually are doing an internal dissection of you, your integrity, and your character. The problem is the mindset. Patients today see doctors as predators and themselves as prey, lack of trust. And we are actually doing the same. We are looking at our patients and their families as predators and unfortunately ourselves as preys. Where are we going wrong? It's time to pause, reconsider. Why, as I always said, start with why. Why is the patient unhappy? Have you ever given it a thought? We need to understand that healing is a purpose. The treatment we met out is a process. And diagnosis is a product of investigations. Do you realize that there is a trichotomy, if not at least a dichotomy here? Healing on one side is based on faith, belief, and trust. And mind you, God and the doctor we alike adore. Bhagwan ki bhi hum puja karte hain, but only when in danger, not before. The danger over, both are requited. हम उनको माफ कर देते हैं, भूल जाते हैं. God's forgotten, and the doctor is slighted. उस पे हम कुछ ना कुछ किसी किस्म का दोष उन पे नाम लगा देते हैं. Treatment is truthfulness, transparency, and empathy. One side of the spectrum. And diagnosis is exactly the opposite. Suspicion, doubt, skepticism. So on one side, we are healing, while on the other side, we are suspecting, doubting. How can these two, which are different forms of thought, positive and negative, gel together? What are the causes of violence? Poor doctors' image created by media and by a few of our black sheep. Very expensive out-of-pocket healthcare in our country. Inadequate security. Impatience and mob mentality. Today everybody has that Amazon Prime. Mujhe abhi ka bhi chahiye. I want instant gratification. Unrealistic expectations in the minds of the patients created by us. Improper communication and consenting. What are the types of violence? Telephonic threats, intimidation, verbal abuse, physical assault, both grievous, simple, and at times non-injurious, even murder, vandalism, and arson. What are the effects on us? Yes, we get depressed. We lose our sleep. We develop PTS or post-traumatic stress situation. Fear and anxiety, fear of the past, anxiety of the future. We stop going for work. We even attempt and at times successfully execute a suicide. What are we requesting the government? We request that there should be no media sensationalism of deaths. Legal steps should be taken by which a patient who has created some scene or there's been a vandalism or an arson, these people's complaint should not be accepted. This lovely auditorium was inaugurated by our past president, and he made a statement. And I've been thinking about it. As doctors, your services must be available both to those who can afford your fees and also to those who are less fortunate and cannot. It is for society to profit from more medical science. It's not from medical science to profit here from society. Are we looking at profits? This is what our police commissioner said. He said, do not treat patients like a commodity. He gave a stern warning to doctors. India, unfortunately, in the eyes of Lancet, has been a big failure as far as police, judiciary, and politicians. And they believe that violence on doctors, 70% in our country, is because of the fact that everybody else seems to be working against us, despite the fact that in 2018, We are still the most respected profession above lawyers, engineers, head teachers, police officers, nurses, accountants, managers, consultants, and secondary school teachers. What are the steps that we can take? This is, as I said, tuition from outside, but from within, what should we do? We should not overreach the prognosis. We should be realistic. We should take a valid, informed consent, detailed writing and documentation. What you say you do and what you do you write and document. Empathetic. Believe you are the patient. Put yourself in their boots and communicate with them. Always be aware of, there is aware that there can be potential violence. This is very recent, this year itself. Orthopedic surgeons are having high prevalence of burnout, depression, and suicide. In these situations, as I always said, remain silent and smile. You can get over it. Nothing lasts forever. This too shall pass. And in any situation, be charming yet correct. Professor Guliani said, do the right thing, meticulously document, do not lose your temper, stay out of danger, never be distressed by insistent patients, investigate the patient's mental state, never shirk difficult patients, give them the time they need, let them talk. Have an open and frank communication. It's a creative art that needs to be developed with each passing day. It's a lifelong pursuit. And as I mentioned yesterday, we all are born with different talents, but we have an equal opportunity to hone those skills. Everyone whom we see is fighting a battle that's not known to us. Please understand there's a lot of distance or difference between expectations and reality. Advice and counseling are most important and form an integral part of treatment far beyond the pharmacology. And we have to give mental health consultations, and they're essential in every aspect of treatment that we met out today. We must always remember nothing in the world can bother you as much as your own mind. We must listen to our patients. We must respect their views, have open communication about all preferences, discuss all options, allow them to speak, ask questions, ensure that they've understood, be aware of their language, accept